Enough about the theory. Now let's talk about the clinical features of neoplasia. The first one here is cachexia, or the wasting. It's not just the lack of appetite, it's a hypermetabolic state driven by TNF-alpha and interleukin-6. The result is loss of muscle and fat equally, unlike starvation. Next one, and very important one for your theory, is paraneoplastic syndrome. These are symptoms that cannot be explained by the local spread of the tumor. For example, acanthosis nigricans, the dark velvety skin in the axilla. It is seen in gastric cancer. Polycythemia. It is seen in renal cell carcinoma due to production of erythropoietin. Trousseau sign. It is a migratory thrombophlebitis seen in pancreatic cancer. Lambert-Eaton syndrome. The muscle weakness mimicking myasthenia gravis. It is seen in small cell lung cancer. Sometimes the tumor produces hormones it shouldn't. Hypercalcemia. It is the most common paraneoplastic syndrome caused by parathyroid hormone. It is seen in squamous cell lung cancer. Cushing syndrome. It is due to excess ACTH seen in small cell lung cancer. The third point here is grading versus staging. Grading is the pathologist's job. We answer how ugly do the cells look under the microscope. It is based on differentiation. While staging is the clinician's job, she asks how far has the fire spread in the body. TNM system is the T for tumor size, N for regional lymph node involvement, and M for distant metastasis. Staging is the single most important predictor of survival and far more important than grading.